Gallbladder cancer (GBC) is an uncommon but highly fatal malignancy. Fewer than 5,000 new cases are diagnosed each year in the United States. The majority are found incidentally in patients undergoing exploration for cholelithiasis. A tumor will be found in 1 to 2% of such cases. The poor prognosis associated with GBC is thought to be related to advanced stage at diagnosis, which is due both to the anatomic position of the gallbladder, and the vagueness and non-specificity of symptoms. Worldwide, there is prominent geographic variability in GBC incidence that correlates with the prevalence of cholelithiasis. High rates of GBC are seen in South American countries, particularly Chile, Bolivia, and Ecuador, as well as some areas of India, Pakistan, Japan, and Korea. In Chile, mortality rates from GBC are the highest in the world. These populations all share a high prevalence of gallstones and/or salmonella infection, both recognized risk factors for GBC. North America is considered a low incidence area. In the United States, GBC is the most common cancer arising in the biliary tract. Estimates from the Surveillance, Epidemiology, and End Results database reveal an incidence of 1 to 2 cases per 100,000 population in the United States. In addition to geography, there are also age, race, and gender-related differences in the incidence of GBC. Incidence steadily increases with age. Women are affected 2 to 6 times more often than men. GBC is more common in Caucasians than in Black people. Several risk factors have been identified for GBC, many of which share a common characteristic of chronic gallbladder inflammation. Gallstones are present in 70 to 90% of patients with GBC. A history of gallstones appears to be one of the strongest risk factors for the development of GBC. The risk is higher with larger gallstones. Patients with stones larger than 3 cm had a 10-fold higher risk of GBC compared with those with stones less than 1 cm. Porcelain gallbladder is an uncommon manifestation of chronic cholecystitis that is characterized by intramural calcification of the gallbladder wall. It is associated with cholelithiasis in more than 95% of cases. The increased risk may be confined to patients with selective mucosal calcification or incomplete mural calcification. Gallbladder polyps are outgrowths of the gallbladder mucosal wall that are usually found incidentally on ultrasonography or after cholecystectomy. A higher risk of gallbladder mass lesions is reported in the chronic inflammatory state associated with primary sclerosing cholangitis. In endemic settings, approximately 1 to 4% of acutely infected individuals become chronic asymptomatic carriers of Salmonella typhi. Several reports and a meta-analysis of 17 case control and cohort studies suggest an association between chronic S. typhi carriage and elevated risk of GBC. Helicobacter colonization of the biliary epithelium, particularly Helicobacter bilis, has been implicated in the pathogenesis of gallbladder disease, including GBC, based on detection of Helicobacter-derived cytotoxins and surface proteins using sensitive molecular and immunohistochemical techniques. Biliary cysts are cystic dilatations that may occur singly or in multiples throughout the bile ducts. Biliary cysts are associated with an increased risk of cancer, particularly cholangiocarcinoma, and the incidence of malignancy varies with age. Anomalous pancreaticobiliary duct junction is a rare anatomic variation in which the pancreatic duct drains into the common bile duct, resulting in a long common channel, usually over 2 cm in length. Anomalous pancreaticobiliary duct junction appears to increase the risk of biliary and pancreatic malignancy. Some drugs have also been implicated in biliary carcinogenesis, including methyl-dopa, oral contraceptives, and isoniazid. Evidence is accumulating that carcinogen exposure may also be involved in the etiology of GBC. An increased risk of GBC has been described in workers in the oil, paper, chemical, shoe, textile, and cellulose acetate fiber manufacturing industries and in minors exposed to radon. Obesity has been consistently associated with an increased risk for GBC. Differences in the demographics, clinical presentation, and gender distribution suggest that there are 2 key pathways to developing GBC in patients with cholelithiasis and an anomalous pancreaticobiliary duct junction. It is hypothesized that chronic irritation of the gallbladder mucosa over a period of years may predispose to malignant transformation or act as a promoter for carcinogenic exposure or genetic predisposition. A second mechanism involves anomalous pancreaticobiliary duct junction, which is associated with a relatively high proportion of cases of GBC. Cancers associated with this condition occur at a younger age, show less female gender bias, and have a lower incidence of associated cholelithiasis. There are also histologic and molecular differences in gallbladder cancer associated with anomalous pancreaticobiliary duct junction and in those associated with gallstones, providing further evidence that two distinct pathogenetic pathways are involved. GBC arising in Japan in the setting of an anomalous pancreaticobiliary duct junction are characterized by KRAS mutations and relatively late onset of p53 mutations. By contrast, at least in Chilean patients with cholelithiasis and chronic cholecystitis, KRAS mutations are rare, while p53 mutations arise early during multistage pathogenesis. GBC may be diagnosed preoperatively, intraoperatively at the time of surgical exploration for abdominal symptoms attributable to another disease process, or postoperatively upon examination of the gallbladder specimen, typically removed for cholecystectomy due to symptomatic cholelithiasis. Patients with early invasive GBC are most often asymptomatic, or they have nonspecific symptoms that mimic or are due to cholelithiasis or cholecystitis. Among symptomatic patients, the most common complaint is pain, followed by anorexia, nausea, or vomiting. The symptoms of advanced gallbladder cancer often differ from usual biliary colic and are more suggestive of malignant disease, malaise or weight loss. Patients who present with a symptom complex suggestive of acute cholecystitis more often have earlier stage disease and a better long-term outcome than those who present otherwise. Physical examination may reveal a palpable gallbladder in a jaundiced patient. The usual initial diagnostic study for presumed benign gallstone-related disease is ultrasound. Many patients with an incidental gallbladder cancer are found retrospectively to have had suspicious ultrasound findings like a solitary or displaced stone, or an intraluminal or invasive mass, that were not recognized preoperatively. Findings that are suggestive but not diagnostic of GBC include mural thickening or calcification, a mass protruding into the lumen, a fixed mass in the gallbladder, loss of the interface between the gallbladder and liver, or direct liver infiltration. Small polypoid lesions within the gallbladder may represent adenoma, papillomas, cholesterolosis, or carcinomas. Polyps over 1 cm in diameter are more likely to contain an invasive cancer than smaller ones. For patients who present with a U.S.-detected gallbladder lesion that may represent GBC and for those who are found to have incidentally diagnosed GBC following simple cholecystectomy, we recommend cross-sectional imaging with CT abdomen and pelvis or MRI, MRCP. On CT, gallbladder cancer can appear as a polypoid mass protruding into the lumen or completely filling it, a focal or diffuse thickening of the gallbladder wall, or a mass in the gallbladder fossa with the gallbladder itself being indiscernible. Liver invasion, suspected nodal involvement, or distant metastasis may be shown. Endoscopic ultrasound is considered to be more accurate for imaging the gallbladder than extracorporeal transabdominal ultrasound. Endoscopic ultrasound is useful both in the detection and differential diagnosis of gallbladder polyps and in staging tumor extent. Endoscopic ultrasound is a useful modality to assess the depth of tumor invasion into the wall of the gallbladder and for defining lymph node involvement in the porta hepatis or parapancreatic regions. Given that distant metastasis can affect the lungs and pleura, consensus-based guidelines recommend cross-sectional imaging of the chest in patients who appear otherwise to be potential candidates for resection. Laboratory studies are generally non-diagnostic, and elevated alkaline phosphatase or serum bilirubin may be related to bile duct obstruction. Serum tumor markers such as carcinoembryonic antigen or carbohydrate antigen 19-9 are often elevated, but they are not diagnostically useful because they lack specificity and sensitivity.